So one more video on the physiology of bone. We're going to clean things up by running through the process of growth, modeling, remodeling, and repair, okay? And so let's start with growth. This is my slide for this. The process is generally demonstrated in this figure on the left. And basically, what you have in the fetus are these hyaline cartilage models. So the way that bone forms in general, you start with cartilage and you kind of use that and shape it to get it kind of like where you want, because it's much, much easier to break down and regenerate cartilage and get it into a nice model. And then after you get things the way you want it, you use that cartilage and you start laying down bone. Okay? It makes no sense to your body to start laying down bone immediately, because the process of breaking it down is pain. And so you can work much more easily with cartilage in the same way that you can work much more easily with clay if you're doing some sort of artwork, where you just want to make a quick and dirty model, and then you use that to make your final product. That's what you're really doing with cartilage here. So we have hyaline cartilage that we're starting with, and the whole process of osteogenesis begins with the fetus here, and doesn't stop until the end of puberty, where your epiphyses seal up, and I'll talk about that in a moment. So we have our cartilage model that serves as your structural scaffold for bone. That cartilage is replaced by an ossification center that forms right in the middle of that bone, in the center of the bone shaft, right here. Okay, and the chondrogenic cells become osteoblasts, and you make bone there. And also the periosteum forms from the perichondrium that surrounds this hyaline cartilage model. When you vascularize that, it becomes periosteum, and you also start to lay down bone on the outside. And so you're growing both this way from your primary ossification center in the center of the bone. You're also growing at the surface, and you're making a collar around that through the periosteum. Okay. The ossification just takes place as you move in both directions toward the ends. And again, as the periosteum, make sure cartilage around that cartilage template, and you thicken that bone as you make it longer. And then you have a secondary ossification center that forms, and you start to get growth and length from the ends right here at what will be the epiphyseal plate. Okay, and what happens here is you've got cartilage being laid down here and toward the ends, and then as you get farther and farther away from that, you start to see that cartilage become bone as osteoblasts break it down. So you've got chondrocytes being formed here, and then they die, and the osteoblasts make bone as you move farther and farther away from that center. And so what happens is the net effect is if you've got more cartilage being made than cartilage being ossified, or if the rate is equal, then what you have is bone growth going on, because you're making more and more cartilage, you're making more and more bone, and the center gets pushed farther and farther away as you grow outward. Okay, and so that is the typical case until later in life. So you've got this race going on between the formation of cartilage and the formation of bone here, and as long as the two are at least equal, your bones keep growing. And then at about age 20, the bone proliferation starts to overtake the cartilage formation in the zone of proliferation here. And eventually it just becomes all bone and you're not making any more cartilage anymore. At that point, your epiphyses have closed and you're not going to get any more bone growth. So if you get, let's say, a teenager or something like that, and you've diagnosed some sort of a growth problem, which we'll talk about in one of the first couple blocks of your second year, I think the second block of your second year, one of the things you're going to want to know is whether that epiphysis is closed, because if it's closed, then you're not going to get any more long bone growth. And so there's a limited amount that you can do for that patient in that case in terms of, well, getting them back toward a normal growth pattern, okay? All right. Finally, once again, I want to emphasize that we do have modeling of bone going on, and that is going on from, during this period as well, where, and of course during all of life, during your whole life, as you put stress on bone, you can stimulate formation of bone in certain areas. And so during the formation of bone, you are modeling bone, you're getting detection of the stress through the osteocytes, and you're getting the laying down of bone in certain areas. You're thickening here, thinning there to allow it to optimally support you. And so it is worth remembering that is taking place here. And we talked mostly about that process on the previous slide, in the previous video when we talked about osteocytes, okay? So finally, let's talk a little bit about remodeling. This is how you both regulate serum calcium through this process, and it also is the process by which you repair micro damage to the bone. And so you do both of these by turning bone over. If you're turning bone over, if you're breaking down bone and then forming it back up, you're breaking down bone in areas where there's micro damage, naturally enough, and so you're reforming fresh bone and you're repairing that damage as you go along. At the same time, as I emphasized in the first video in this series, if you alter the balance between the osteoclasts and the osteoblasts, you can shift things toward breaking down more bone than you're making as you're turning it over, and then you can increase bone, or if you can do it the opposite way, you can increase serum calcium, or if you do it the opposite way, you can decrease serum calcium by making the osteoblastic activity more predominant, okay? So both of those are involved in remodeling, and it's basically all revolving around the process of bone turnover. So in terms of turnover, the first thing you naturally have to do is break bone down. So naturally enough, you start with the osteoclasts. The osteoclasts break down bone, and then what's going to happen is that after that breakdown takes place, you're going to signal osteoblasts to come in and form and fill in that pit that you've made with the osteoclasts. And at that point, you'll have remade fresh bone. Okay, so this process is going on all the time. In fact, if you look at the way that this works, on balance, until you're 20 to 30 years old, you're going to get more osteoblastic activity than you're going to get osteoclastic activity, and of course that means you're going to get growth. After about 40 years of age, that shifts, and all of a sudden you've got more osteoclastic activity than osteoblastic activity, and so you actually lose bone. And this is largely due to decreased estrogen in women and testosterone in men. We're going to talk about that in a moment. Okay, but that shifts this process more toward bone resorption, and you get more osteoclastic activity and a little bit less filling in by the osteoblastic activity. Okay, so let's talk a little bit about how this works. Again, you've got this process by which you're activating osteoblasts, and those osteoblasts are activating the formation of osteoclasts, and this is how you get turnover of bone. And so at the beginning of this process, the osteoclasts predominate, and you're getting excavation of a pit by the osteoclast in this bone when you're remodeling. And then what happens eventually after a period of like 10 days, I can't remember what I said in the notes, 10 days, 2 weeks, something like that, I think. Progerin, henceforth known as OPG, something I can pronounce, is secreted by osteoblasts, okay? And what this is it's a decoy receptor for this rank L. So this rank L is the ligand for rank, okay? And so what happens is, instead of binding the rank receptor, it starts to bind this OPG. And so what that does is it causes less osteoclast to be produced, less osteoclastic activity, and it seems to be involved in this signal for osteoclastic activity to stop in these pits and for osteoblasts to come in and fill in and start to make bone, okay? And so that's one of the primary signals for how that happens, okay? And so once that happens, you get this filling in by the osteoblasts and you get net bone formation in an area rather than bone breakdown by osteoclasts, okay? Again, regulation of this process, parathyroid hormone, vitamin D, calcitonin, we've talked a little bit about that in the first video. It's going to be the primary topic of the next lecture, so I'm not going to emphasize it here. In fact, this chart is from the next lesson, so you'll get it there. Growth hormone and thyroid hormone we'll talk about in the future. You have a block in your second year called growth and development, and I'll be talking a lot about that and its effect on calcium homeostasis in that block. I'll have at least one lecture on that. Glucocorticoids increase osteoclastic activity, decrease osteoblastic activity, okay? That's important to note because if you're treating someone with cortisol, which is an immunosuppressant, or corticosteroids, if you're treating someone with the corticosteroids, they will act like this as well. And so one of the things that you'll look for if you've got a patient that you think might be having a bone problem is whether they're possibly on corticosteroids. Toward the end of this, the notes for this lesson, I have a USMLE stem, and the woman in that stem is older, she's got arthritis, and so she's probably on corticosteroids. And so, given that that's the case, she may have hypercortisolism, and a side effect of that may be increased bone reabsorption, decreased bone formation, and so that could contribute to contribute to her problem, which is probably osteoporosis. Okay, she's an older woman, postmenopausal. So I've got this figure in your notes. On balance, in the presence of PTH and vitamin D, you predominantly have osteolysis. And the reason for that, one primary reason for that, is that your body secretes PTH when your serum calcium goes down. And so what happens is you want to increase serum calcium, you'll break bone down. Talk about that in the next lesson. On balance, estrogen and testosterone, which I mentioned a minute ago, will cause osteogenesis. And this is why, on balance, most of you who are watching this in your 20s, you have nice high testosterone levels, nice high estrogen levels. On balance, you're still growing a little bit. Part of that, the reason for that is because you've got nice high estrogen and testosterone, okay? On the other hand, if you decrease estrogen and testosterone as you get older, as you will find out, and as I can attest, that will cause you to have less osteogenesis. And that can cause you to start breaking down bone on balance. And that's the reason why after about 40 or so, you start to lose bone rather than gain it, okay? It's largely because of the drop in these hormones. So let's talk a little bit about estrogen. We have two things going on with estrogen. Estrogen binds receptors in the nucleus of osteoblasts and osteoclasts, and it binds to receptors in the cytosol in osteoblasts and osteoclasts. Okay? In the nucleus, when it binds, it decreases the rate of bone turnover. And when you decrease the rate of bone turnover, generally speaking, what that means, generally, physiologically, is that you're on balance producing more bone than you're breaking down. Okay? Remember way back in the first video, increased PTH, increased bone turnover, and on balance, you shifted toward osteoclastic activity and you were breaking down more bone. Estrogen and testosterone do the opposite. They decrease bone turnover, and in the process, the osteoblasts win, and you form more bone. Okay? In the case of, or I shouldn't have said that. In the case of estrogen and testosterone, they do the opposite in that they decrease the rate of bone turnover. And they do shift the balance toward bone formation. But in the case of the nuclear receptors, it seems, oddly enough, that the osteoblastic and osteoclastic activity balance out. So as you decrease the turnover, you decrease both activities by estrogen and testosterone by the nuclear mechanism. Both activities go down in parallel. So you decrease bone turnover, but you decrease both the same. So when you decrease estrogen, due to the effect of the nuclear mechanism, you are increasing bone turnover, you're increasing both the same. So I hear you're asking, if I'm increasing both the same, why does estrogen cause more bone formation? The reason is because it binds to this cytosolic receptor as well. And so the cytosolic receptor, when estrogen is present, it increases the apoptosis of osteoclasts, and it decreases the apoptosis of osteoblasts. And so what happens is you have osteoblasts surviving longer, you have osteoclasts not surviving as long. So in the presence of estrogen, the reason why you get a shift toward osteoblastic activity is because of this mechanism, the fact that estrogen is causing the osteoblast to stick around longer. All right. So if we decrease estrogen, like in osteoporosis, the opposite happens. You decrease the apoptosis of osteoclasts, they live longer, increasing the breakdown of bone, and you increase the apoptosis of osteoblasts, they live a shorter period of time, so you're making less bone. And that causes the imbalance that you see with osteoporosis. Decreased estrogen causes osteoclasts to live longer, osteoblasts not to live as long, and you get more bone breakdown. You get women and men with brittle bones, okay? So we have decreased estrogen and testosterone, which increases the rate of bone turnover, but it increases both osteoblasts and osteoclasts equally. And then the imbalance is caused by this extranuclear mechanism, the cytosolic mechanism, where we're causing the osteoclasts to live longer, okay? And we're causing the osteoblasts to live a shorter period of time. All right? Got that? Same hormones, two separate mechanisms. The end result is what you see medically, which is older men and women with thinner bones, osteoporosis. Okay? All right. So, and I have a USMLE STEM in your notes. You may want to go through that. It talks about this woman, and she's not very active because she's got arthritis. And so naturally, her bones are remodeled in such a way that they're thin to begin with, probably. And then She's got arthritis, so she's probably being treated with corticosteroids, which means that she's probably got a nice increase in breakdown due to that, if she is. And then on top of that, she's postmenopausal, which is a good indication that her estrogen is down, which means that she's breaking down more bone, which is osteoporosis. And on top of that, her mother died due to surgical complications when she fell and broke her hip, and which probably means that she also had osteoporosis. So, you know, there's a history there of it in the family. All right, so you look at that stem, you can kind of see some of the cues that you get. They probably aren't obvious when they're buried in the middle of hundreds of questions, but nevertheless, I think you can work your way through that, and you can see where that stem is coming from. Something to pay attention to, all right? So let's do the repair of bone really quick. First of all, the bone breaks, you hemorrhage into the area, and a hematoma develops where the bone is broken, okay? And that, naturally enough, forms a nice network of fiber where a clot forms. And those serve as the initial anchors for some of the precursor cells that are going to migrate into the area. You have new capillaries that grow in. You have periosteum that proliferates here around that break in the bone, okay? And connective tissue is formed and cartilage is formed in the area, and you form what's known as a soft callus. That is, you've connected your bones up again with this soft cartilage, okay? And once again, we're going to use cartilage as a model to make bone, just like we did with bone growth, okay? So we start with cartilage with the soft callus. Then naturally enough, as you might guess, there's our periosteum, there's our soft callus forming, and then, as you might guess, osteoblasts come in and they begin to lay down bone. Here, they use your cartilage as a model to make the bone. They come in, they invade, they make bone, and the result is a hard callus, which is woven bone with just collagen fibers kind of woven through it. It's kind of random as opposed to nice organized lamellar bone. But what you'll do over time is you'll remodel that, and eventually it'll go from being this sort of disorganized hard callus into regular lamellar bone, okay? And your bone will have been repaired, all right? So that was the last thing I wanted to take you through. Thank you for your attention, and we'll move on to calcium and phosphate regulation when you're ready to start that series of videos.